This show highlights the incredible range of academic and experiential backgrounds that shape the people working in healthcare quality, patient safety, and infection prevention and control. In each episode, you will meet professionals who found their way into these fields through very different paths. We talk about personal and career journeys, hiring and retention challenges, professional lessons, and the value of certification. I'm your host, Ivan Goe. Welcome to the Safety Spectrum. Hello, and welcome to the Safety Spectrum podcast. I am very excited for my first international guests today. Secondly, my background is lab, as you know, and in the lab, we work very closely with pathologists, and my guests today are pathologists, and so I feel a professional kinship to them. And even beyond that, they're pathologists who are venturing into the field of infection prevention and control and practicing in India. I'm joined today by Dr. Arora and Dr. Gupta from Pathology Mentor. Welcome, gentlemen.
Yeah, thank you, Ivan, for an introduction to your. So, I'm Dr. Raman. So, I'm basically a founder of Pathology Mentor classes, and we are venturing into this field of infection control practices, where we are taking the microbiologist, a doctor, to becoming a chairman and a leader in this field. So, the idea behind was we were always looking for people where they can get trained for this, because as of in India, we don't have any specific credentially programs available, and our degrees are allows us to practice as infection control specialist, but there are no specific certifications or any accreditations which were available. So the idea behind starting this whole program was we'll start from the basics, take them to the implementation, and then when they are implemented and when they're certified to become infection control, when they implement those things in the hospital, we'll be working in close collaboration with them, where it may be in form of a consultancy or even helping them in each and every field from where they face problems in them. Yeah, Dr. Ankit, would you like to say something about it?
So hi Ivan, hi Dr. Arora. So Ivan, my name is Dr. Ankit Gupta. So as Dr. Arora mentioned, we all are pathologists, but I belong to a sister concern branch which is called as microbiology.
Okay.
So on this side of continent, we have a separate specialty by the name of microbiology, which dealing with the diagnosis of infectious diseases from a lab perspective. And as a clinician perspective, we also delve into the infection prevention and control practices. So fortunately, both happens to be my core areas of interest. And as already elucidated by Dr. Arora, in India, microbiology as a specialty itself trains you to be a infection preventionist in a respective healthcare institute. So hence being the journey. So it's a privilege of being associated with pathology mentors, wherein we can lay a path for our fellow physicians to follow these practices, make them easier to comprehend and implement them in their respective institutions. So here we are with a collective thought of processing and progressive knowledge.
Wonderful. All right. I encountered Pathology Mentor on LinkedIn. You posted something about a physician championing infection prevention and control, coming from a pathology background, and so that's honestly what caught my interest and caused me to reach out, because, like I said, coming from the lab, pathologists are people, and I've never met pathologists in infection prevention and control. So, if I'm understanding you correctly, the key connection for pathology and infection prevention in your practice is that you are experts in microbiology.
Right.
You are. Okay. All right. And that is exactly how I got into infection prevention and control too, because I trained and worked in the lab and worked in microbiology for a bit, and then this field seemed like the next logical thing with regards to implementing the implementing microbiological practices in a healthcare setting. So, all right. So what sparked this interest? How did you get into infection prevention and control? Was there a moment where you thought, you know what, this is, I don't know, what sparked the interest?
When we started this journey of doing accreditations for quality for our labs, we realized so many infection control practices were missing from the lab.
Mm-hmm.
So the idea behind training my staff accordingly, how to dispose, what type of material has to be disposed in what type of dustbins, basics, some basics also, even when they are withdrawing samples, and
Mm-hmm.
how the cleaning of the area has to be done. So all these small things kept on adding. Then that led me to believe, okay, we should move into this field, which is a very basic steps. But if you miss out, it can be very catastrophic for the patient. So the idea was behind this, and moreover, not only this, even small things like needle stick injury, which is a
Mm-hmm.
major part of hospital infection control practices. Many of the our technical staff, they were inhabited of just squeezing them the finger or doing something else. They were not well versed with the whole how to go about if they even get a small needle stick injury, and if they don't know the whereabouts of the patient, whether the patient is hepatitis B is positive, C positive, or HIV positive, so
Mm-hmm.
how they should go about. So all these things only helped us in believing that we should move this subject ahead and implement them properly in our labs. And same we tried to extrapolate in our collection centers or the sample collection center which we have throughout the hospital. So this is
Okay.
how we started implementing hospital infection control. Yeah.
Nice. Dr. Ankit?
Okay. So, Ivan, as I mentioned, that we have a specialty by the name of microbiology in India. So, here we try to establish a concept called as from bench to bedside.
Okay.
Now, when we talk about bench, you are already a lab professional. So, bench would
Yes.
mean, yeah. So, bench is like what I will say, it is our sacrosanct place where we read the culture plates, we inoculate the samples.
Mm-hmm.
So we started that why don't we read the culture plate also, get acquainted with the pathogen which has grown in the plate, that is what we call as a petri dish,
Mm-hmm.
and why not extrapolate our information and knowledge to the patient from which this bacteria or this pathogenic organism was isolated.
Okay.
So once we tried to start our journey from bench and end it at bedside, probably we are able to fill in many gaps, many voids which do happen in patient safety.
Mm-hmm.
And just taking ahead Dr. Arora's feedback that this infection prevention is not only limited to one area of the hospital.
Yes.
It encompasses all the areas, be it be a lab, be it be a collection center, be it be a ICU, be it be a normal inpatient department where ambulatory patients are admitted. And above all, sometimes we forget the importance of a support and enabling areas in maintaining this journey. Let's
Mm-hmm.
say food and beverage department, engineering department. So as a clinician, while we are working in the labs, we are able to, how do you say, extrapolate our lab information to the clinical information and then try our level best how we can prevent the spread of infection in our hospital or our healthcare facilities.
That's wonderful. One of the things that we talk a lot about healthcare in the U.S. is just safety, right? Safety for patients and safety for staff. In my own infection prevention practice, essentially, I described my role as keeping patients safe and keeping staff safe. And just as you are doing, you started out with your staff, but it keeps going, right? It keeps going, and you have to keep the patient safe, or else people are not going to come back to your hospital. You have to keep your staff safe, or nobody's going to work there, right? And so all of these things are encompassed in safety. I'm going to go on a leap here and you are both familiar with the father of hand hygiene, Ignaz Semmelweis, correct?
Yes.
In is your experience in starting these programs and implementing them in hospitals in any way similar to Ignaz's experience training hand hygiene in Vienna?
Okay. Ivan, thank you for raising this question, because this is something in and out. If you assess the staff, uh, really, when you do a risk management or a safety assessment, you realize there's so much of to do in this field.
Uh-huh.
And for them, still to make them understand this hand hygiene thing, the steps of hand hygiene, and making the real importance of behind that is a big task. Even though it looks
Uh-huh.
so simple, that just training them on hand hygiene is so simple, but when it comes to the ground, uh, matlab your sample is on the with a bare hand, and your gloves is on the other hand. So that is something which we face every day. And with the same hand, they have a habit of even having the food also. So that is something, and making the understand each and every step uh, is difficult. Well, we have implemented so many posters, we have done so many challenges, we have even given them quizzes. But if you ask me, we have still been able to reach to well, approximately 70 to 80%.
That's
So,
amazing.
as a lab administrator or a lab professional, this is something which I face every day. Not only this, even if I go to the nursing staff, there also we has sometimes have a challenge, because when the new nurses come, make them understand, it's a real challenge. So we keep on doing all those programs. And Dr. Ankit, I'm 100% sure, has been conducting many training programs for doing this, and I think his feedback also should be the same. Yeah,
Yeah.
Dr.
So,
Ankit.
what kind of training do you provide with regards to hand hygiene and all of those things in the hospitals and labs?
So, Ivan, I completely reciprocate and second the thought shared by Dr. Arora. So, we have tried to inculcate the habit of hand hygiene on 2 or 3 levels, with an emotional touch, with a
Okay.
spiritual touch, and with a medical touch. Emotional means we always say that as a healthcare personnel, we never discriminate between any kind of a patient. For us, a patient is a patient. Similarly, for the microbes, they also do not discriminate between any kind of strata of people.
Yes.
So once we tell them that you have to wash your hands, come what may, then people have understood the importance of hand hygiene. If I talk about spiritually, like we follow a certain god or we believe in a certain higher power. So we tell them the way you worship the higher power, similarly consider it as a utmost activity for the infection prevention. And though not the last but not the least, so we try to customize our training programs as per the audience. Let's, for example, a doctor, a busy doctor who is walking here, there, and round. So we try to go with them, telling the importance of hand hygiene. If there are nursing staff or paramedical staff, we try to inculcate this knowledge by doing some interactive quizzes, games, creating some rhyming poems around them. And for the people who are working in the support staff, again, we tell them the importance of hand hygiene in their own respective fields. For example, a person who's working in the kitchen, he should wash his hands so that he does not transmit his germs to the in the hospital.
Yes. Yes.
Person who is taking care of the hospital surrounding, he should wash his hands so that at the end of the day, he does not transmit one organism to the another. And what we tell every single healthcare personnel in our respective institutions, before going back to home, please do wash your hands. So these are certain tricks, treats, and which keep on helping us propagate this message. So we are trying to inculcate and take ahead the practice which Ignaz Semmelweis started by using a chlorinated lime and
Yes.
the way he brought down the risk of peripheral sepsis.
Yes, absolutely. I have practiced infection prevention and control for 17 years, and every year, is, you know, a hand hygiene program. How are we going to do hand hygiene differently this year? Because, like Dr. Raman said, it's a very simple intervention. Yet for some reason, it is so difficult to implement as clinicians are going about their work. One of the things that I have personally learned is, when I started out in infection prevention and control, I always thought, well, they just don't want to. They just don't care about safety. But it often comes down to how our processes are set up. When you come into the room, is there access to hand hygiene materials, whether it's alcohol-based hand rub or sinks, and when you get, what comes first, the gloves or the hand hygiene, right? As they just physically walk through a room, what comes first, and all of those things. And so it's a constant struggle. So you're not alone. I'll tell you that. I'll tell you that you are not alone in the battle for hand hygiene. All right. So you both practice in hospitals, in addition to your labs, in addition to the education that you're providing, and you are leaders in this field, in those hospitals. How accepting of these practices are your fellow physicians who are working in those hospitals, but also how accepting are the hospital administrators to the practices that you are teaching?
Okay. So I would like to share insight. If I talk about the hospital administration, once initially, maybe I talk about 15 years back, when we didn't have any accreditations like JCI accreditations or NABH accreditations, that time talking about hand hygiene was like as if we were speaking Greek.
Mm-hmm. Wow.
Now, with time, when the accreditations have come into practice, if you talk about NABH, which is an Indian way of accrediting the hospitals, or JCI, which is an American way of accrediting the hospitals, now administration wants 100% implementation of these hand hygiene practices, because now they have realized the amount of backlash from the patient they have to bear if a patient gets an infection in the hospital.
Okay. All right.
So now they have tuned to that, and they are very much pro for it. Even they don't mind spending a good amount. When we even create jingles, we create posters, and even we tell them that each and every area we need to put all this hand hygiene material, as you said, in all these places. They never say no to it. They said, only what we want is 100% implementation on those. I'm talking about great corporate hospitals, so they've become very much pro for it, which was not there 15 years back, but now things are changing.
That's amazing.
Clinicians or the associates, they are also have become now, they are very happy if their cases go without any hospital-acquired infection. So their mindset is also changing. Even they might be very busy surgeons, but this concept is changing. Initially, it was maybe 15, 20 years back. If you used to go to in the OT, they were using the same gloved hand with their phones also, when the more mobile phone. But now that things have changed. But if the doctor is scrubbed, he will not take your call inside the OT. So things are changing. They will not take any of their personal belongings inside the hospital, in the OT specifically. And they're very much concerned about it, because now they realize if they follow this hospital infection control practices, their patient outcome will be better. And now things are changing. Only some level of the lower level, of the ground level, we are facing more of trouble rather than the doctors itself. So, I think Ankit will be able to tell us better, because he has been doing the cultures in different OTs and patient wound areas also. And what is his been culture practices, what he has seen in those, so he'll be able to comment on better. Yeah.
Before you do that, I would like to clarify for our American audience, OT is operating theater, right?
Yeah.
Yes. Look at me knowing things. All right, go ahead, Dr. Ankit.
Okay, thank you, Dr. Raman. So, Ivan, we have been progressively seeing a increased adherence and compliance to the practices of hand hygiene, because you must be knowing about World Hand Hygiene Day and Global Hand Washing Day.
Yes, absolutely.
So what happens when these 2 days, that like 5th May is celebrated as World Hand Hygiene Day and 15th October is celebrated as Global Hand Washing Day. So we tend to celebrate these days not as days, but as a festival with great pomp and show. And in these kind of festivals, I am calling these as festivals because it is actually a celebration of those people who have followed the practices, celebration of the people in the administration who have made these resources available, and celebration of the patients, because we have seen that patients have also becoming very, very cautious, curious, and vigilant about which kind of healthcare workers are following their hands. So what we say that even if you have not touched a patient, you might have touched a patient's surroundings which may be teeming with bacteria. So over these years, yes, the point is well said. There is a challenge and there is a constant challenge, but probably by constant engagement with the healthcare staff, both at the upper, middle, and lower level, we are able to change the mindset and tell them the importance of a 30 or 60-second practice, which can translate into a patient safety.
That's
already
wonderful.
The accreditation bodies like JCI for rest of the globe and NABH for India, they have taken these indicators as a continuous quality indicators for the hospital.
Yeah.
So we do quantify the percentage of hand hygiene across our facilities with respect to the various movements, with respect to the various cadre of staff, so that where we can see where is the opportunity of improvement, where the improvement is happening, and where are the things are plateauing, so that we can take an appropriate corrective and preventive action, as we are very much fond of using this word as RCA and CA and PA. Root cause analysis, corrective action, and preventive action.
Nice. That's amazing. Yeah, you guys are doing great work. This is so exciting. All right. When you provide education, you are educating pretty much like the whole healthcare, spread of staff. You are not just focused on doctors or nurses, and are you also training up and coming physicians?
Yeah.
Like,
we are training upcoming physicians. But we are not only limited to the physicians. We have started putting these habits in the patients also, particularly the caregivers of the patient. So they also have started understanding that these practices are important for their own patient or their relatives' health. So they have started, particularly when sometimes when we do an surgery and the patient has to be sent home, and it's an open wound or it's a wound where the dressing has to be done every day. First we teach them how to do the hand hygiene and how to start the dressing. So they also have been following these principles very well. All those things have become very important now. So the junior ones, they start when they enter this field, and we start training at the lower level, and then when they move to a senior level, they're almost into the well-trained areas. So, and they know the importance of it.
Yeah, that's wonderful. That's wonderful. All right, gentlemen. Is there anything else that you'd like to talk about?
Yeah, that's what Ivan, I wanted to talk to you about, because at PMC now we started this dream of training more and more professionals, because when we started this journey, there was no one to train us. We had our degrees where we are believed to carry on with all this infection control practices, but there was no one to guide us. So the idea behind is to create a mentorship program for all these upcoming physicians or even the people who are in this practice. So to train them to reach to a level when they become a champions, because
Mm-hmm.
we want to eradicate this hospital acquired infections so that a patient who comes for a treatment should not be have enough increased morbidity because of this. So the
Mm-hmm.
idea behind this and what we have done in this course, what we've done, instead of just going for some theoretical aspects, we've taken real life scenarios and we are trying to teach them key, okay, if you face this type of scenario, how to go about, how to
Mm-hmm.
implement this, and how to understand the international guidelines, or maybe even you want to implement some CDC guidelines, how to implement them. Suppose you have a break. Last around 6 months back, we had a break of a chicken pox in the hospital. So
Okay.
how to isolate those healthcare workers was a challenge, because
Mm-hmm.
suddenly it came up, and how to
Okay.
isolate them, that was a challenge for us. So these things we have put them all in our course, and we are
Uh-huh.
this modules, and we are trying to teach them with the help of this life scenarios, so they are able to comprehend better. And we are not leave them at this point. Once they are in, when they have done the certification program, when they implement these practices in their hospital, we are there to help them.
Okay.
It is not that it is just a, I'll say, agreement is not only till the classes are over. Once
Uh-huh.
they go into the practice, this will go on,
Yeah.
and
Yes.
keep on learning from their experiences also, which will help us to improve everything better.
Hence mentor, right? A mentor usually doesn't stop. You both keep growing. Yes, the mentor and the mentored person, you just keep growing together. That's good. Good. Uh, Dr. Ankit, anything to add?
So Dr. Arora has rightly summed it up that we are not only mentoring, we are giving a progressive mentorship. Progressive means like the concept of the hand hygiene has stayed from day one. The now until and unless there is some structural change happen in our hands, the process of the hand hygiene will remain the same.
Mm-hmm.
But as we know that there is a new outbreak which happens in certain part of the world, so how to keep our upcoming physicians and also the physicians who are already in the practice, we would like to equip them with a certain degree of confidence that yes, they can implement a program in their own facility with a certain degree of mentorship and look out the things which are available, but is it the right thing to do?
Mm-hmm.
Is it the right thing to do? How to do it? When to do it? How it can be done? But all this program will be is based on the clinical scenarios wherein we have seen an intervention and seen the results. We can call it as progressive mentorship, come coaching, come guidelines. Our focus will be more on the implementation in the real way scenario rather than teaching them the ABC. Rather, construct the sentence, construct the phrase, and then set up your way out and to be a infection preventionist. And one more
Mm-hmm.
thing I would like to add on this side
Yes.
of continent, we usually it was being called as hospital infection control,
Yes. Yeah.
control of infection in the hospital.
Mm-hmm.
But over a period of time, the term has evolved into infection prevention and control,
Mm-hmm.
with the focus being on more on the prevention along with control and not keeping only to a hospital, but let's say it should start with the patient caregivers, as Dr. Arora pointed out. It can be a nursing home, it can be
Mm-hmm.
a dispensary, it can be any other health facility where patient is going for a treatment. So by uh, making it infection prevention and control, it has been made into more of a holistic activity which would start from the patient, its community, the patient's arrival in the hospital, and once the patient is discharged, the similar practice goes so as to make it a less morbid for the patient. So it is say, let's say, it's more of a holistic concept consolidated into everything. So it's a bigger
Yes.
picture that we are trying to canvas with our efforts.
Yeah. Absolutely. I like I said, I've been in practice for 17 years, and I think probably in the last 5 years, 5 to 7 years, we've started to see more of infection prevention and control. When I started out, it was just infection control. It was just infection control all the time, and so yes, we have to be proactive, right?
Yes.
What's the old adage? And an ounce of prevention is worth more than a pound of cure, or something like that. We have to we have to be proactive. All right, gentlemen, thank you so much. It was a pleasure to talk to you, and you are doing exciting work, and I wish you all the best.
Thank you, man.
Thank you, Evan. Thank you for inviting us. Thank you.
You.